Good afternoon and welcome to our November ICE webinar. Today we are joined by Darlene Humphries, Director of MRI Accreditation at the Intersocietal Accreditation Commission. ICE webinars would like to thank the IAC. Since 1991, the IAC has operated as a non-profit accrediting facilities that provide vascular testing, echocardiography, nuclear PET, MRI, diagnostic CT, and intervention-based procedures under its mission of improving healthcare through accreditation. More than 14,000 IAC-accredited sites have implemented standardized and optimized processes, experienced cost reductions, and most importantly, continuously improved their patient outcomes. So for more information and to learn more about the IAC, please visit intersocietal.org. Now, just a quick reminder to save the date for our 2026 ICE Expo, which will take place at the San Antonio Marriott River Center in Texas, and that's February the 20th to the 22nd. Now, the Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, radiology technologists, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. So for registration and event details, please visit attendice.com. Okay, today's webinar is eligible for one Art Category A CE credit by the ARHA. You can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your one CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on your dashboard. Let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. November is Lung Cancer Awareness Month. What colour ribbon is associated with lung cancer awareness? Answer now using the questions feature on your dashboard, and I'll reveal the answer and the winner at the end of the webinar. As I mentioned earlier, our presenter today is Darlene Humphries, and she will be discussing quality improvement and you, how to develop a quality improvement program. So Darlene, you may begin whenever you're ready.
Thank you so much, Linda. Good afternoon. Welcome to our presentation of quality improvement and you. The purpose of this webinar is to help you define quality improvement, identify key characteristics of quality improvement, explain the 5 phases of quality improvement, create a quality improvement program. Quality improvement is defined as a systemic, ongoing process of analyzing performance and implementing changes to achieve measurable improvements in product, services, patient care, and outcomes. Well, that is a mouthful, but quality improvement can be a defining standard to apply in every aspect of your career. The key characteristics of a quality improvement program will involve structured methodologies and frameworks to guide improvement efforts, states that decisions are based on collecting and analyzing reliable data to identify problems and measure the impact of changes, examines the processes and systems within an organization to find where missteps occur and how to prevent them. It has to consider the needs and goals of customers, including patients and other stakeholders when making changes, and encourages the participation of staff and subject matter experts at all levels to identify issues and implement solutions. The QI process should be a continuous cycle of planning, doing, studying, and acting to make ongoing improvements. The process is flexible and adaptive to changes. Every quality improvement program can also use some improvement. Benefits of a quality improvement program. This seems like a lot of work and stress. Why would you want to put yourself through it? Well, there are a lot of benefits to having a strong quality improvement program that includes improved patient outcomes, increased efficiency, enhanced safety, financial benefits, and better organizational performance. So how to get started? It can be difficult to know where to begin. You can start with the 5 phases of a quality improvement program, which do tie into the key characteristics that we already discussed. Define, measure, analyze, improve, and control. Define. Clearly define the problem or opportunity, set project goals, and understand patient requirements. Measure. Collect data on the current process and establish baseline performance. Analyze. Analyze the collected data to identify the root cause of the problem. Develop. Select and implement solutions that address the root causes of the problem. And control. Establish systems and processes to sustain improvements and prevent a return to the old process. So let's dig a little deeper. Define. Determine exactly what it is that you need to examine. Look at the big picture, how your facility functions, the needs of your patients and staff. You need to do that in order to find opportunities for improvement. Measure. This is the act of establishing a baseline performance and thresholds in a quality improvement program. Clearly identify what constitutes good and bad performance. You will use these benchmarks to track and assess progress over time. Analyze. Collate and prepare the data in a way you are comfortable so you can confidently share with stakeholders. It may be through a spreadsheet or pie charts or other platforms, but you want to determine how you can best share this information. Improve. Of course, the objective is to improve in the areas that you have identified. With a QI program, you can demonstrate your diligent work and pinpoint your improvement and also find opportunities for refinement. Control. Did you ever achieve a goal that you have put in blood, sweat, and tears to, only to lose focus and have a relapse? It can be such a disappointment. Nobody likes to backslide, especially when so much work has been done to demonstrate improvement. This will happen, but having a robust quality improvement program will quickly identify any regression and steps that can be taken before things worsen. So let's have an example of setting up a metric for a quality improvement program. Define. You have received complaints from patients that they're waiting too long in the waiting room. Measure. Take a little bit of time to review the issue. You take 2 weeks evaluating the time it takes from when a patient arrives to when a patient is taken back for their exam. You get an average wait time and determine your threshold of when intervention is necessary. You also observe the process of checking in the patients. Analyze. During your observations, you find a couple reasons for the delayed processing of the patient. Too many patients are being scheduled for different exams, and they're all arriving at the same time. Your single front desk staff member can only deal with one at a time. The second issue, one of the front desk computers was having technical issues, frequently shutting down. And a third issue, one staff member is frequently late, causing a backup of patients. Now you're to the improve. Now that you've defined, measured, and analyzed the problem, you can take steps to improve the issues. Staff is adjusted so that when there is a backup of patients to be logged in, the front desk person will have additional staff support for faster patient check-in. The one front desk computer is replaced, and the chronically late staff member is evaluated and reprimanded for tardiness. Now we're at control. This metric does not always mean bad news. Like we said earlier, this will identify any regression, but it will also define any new variables that may crop up. So your quality improvement plan remains flexible and fluid to address different needs of your patients and your facility. Time constraints. It is understood that the imaging departments are doing more with less, and the burden of adding a quality improvement program can be daunting. Completing tasks in small bites and delegating work to others can be ways to manage this program, as well as elevating your employees to administrative duties. You want this program to be manageable. It would be nice to say you're going to review 50% of the scans that you do, but that is not practical. You can start off small and increase as you and your staff have time. One facility I've worked at did a review of all the scans they did on a Saturday. You can set your own parameters. Streamlining your program can also help you manage your time. Identify the items that you want to analyze. Keeping the focus on patient care, safety, and image quality will reduce project creep and really make your QI program meaningful. You may think that a metric is very meaningful, so you analyze that within your program. If you determine that a particular metric doesn't give you a lot of important data or any means of improvement, you can always throw that one out. The Intersocietal Accreditation Commission has very defined requirements for a quality improvement program that consists of only 4 measures, but more on that later. Thresholds. A key element to your QI program is the determination of thresholds. You need to identify limits for every measure in your program. If you fall below that limit, you know there is a problem. Thresholds will determine the success of your QI program and identify where improvement is needed. Corrective action plans. When your testing results fall below your previously determined thresholds, you will need to initiate a corrective action plan. These plans must be specific to each quality improvement measure and have defined actions that will evoke rapid corrections. Documentation is crucial with corrective action plans. Your stakeholders will appreciate that you have found deficiencies, but will appreciate more what you are doing to make corrections. So what should be included in your quality improvement program? You can tailor your program to address your specific needs. IAC identifies 4 quality improvement measures that must be in every quality improvement program. They include test appropriateness, technical quality review, interpretive quality review, and final report completeness and timeliness. Test appropriateness. This is based on the order from the clinician and the clinical history from the patient. You need to look at the orders from the referring clinician and make sure that the order coincides with what the patient is saying. If there is a discrepancy, you need to confirm the orders with the referring clinician. You can categorize test appropriateness as appropriate or usually appropriate, may be appropriate, and rarely, usually not appropriate. Technical quality review, or also called image quality review. The image quality must be evaluated based on general requirements for the specific modality. This would include, but is not limited to, MRI, artifacts, motion, appropriate parameters, and exclusion of required anatomical structures. CT, artifacts, motion, detector starvation, overscanning or underscanning, and contrast bolus. And in nuclear medicine, artifacts, patient motion, adequate count density, proper gating, and processing alignment. Interpretive quality review is also known as peer review. All of your interpreting physicians should be participating in this aspect of your quality improvement program. Case studies must be sent to a second or third interpreting physician for either a blind, double-blind reading or an outright evaluation of the interpretation. In a blind reading, all interpretations are evaluated by yet another interpreting physician to see if the report or reports are accurate. Remember, it doesn't matter how good image quality is. If it's not interpreted correctly, the patient is not helped. Common peer review classifications. 1, concur with original report. 2A, minor discrepancy, unlikely to be significant. 2B, minor discrepancy, likely to be significant. 3A, discrepancy should be made most of the time, unlikely to be clinically significant. 3B, discrepancy should be made most of the time, likely to be clinically significant. 4A, discrepancy should be made all of the time, unlikely to be clinically significant. And 4B, discrepancy should be made all of the time, likely to be clinically significant. If these classifications are used, it is easy to see where the interpreting physician excels or struggles. The 3B and 4B classifications are always the most worrisome as there is a clinical impact. Interpretive quality review is likely the most time-consuming portion of your program and must be done by other interpreting physicians. If there is a bottleneck, this is where it will be. As this is the most frustrating area, it is also the most essential. This portion of the QI program will help you determine if your interpreting physician is struggling in any aspect of reporting. Corrective action plans would include requesting an interpreting physician receive additional training or supervision. It is crucial to inform your interpreting physicians that this is not a punitive review, but an educational one. Everyone who participates in this review must have that frame of mind. Final report completeness and timeliness. For the report review, it is important to confirm that reports contain all the required elements from your accrediting organization. For IAC, the reports must have the following items: patient ID or name, date of birth, name of the exam, date of the exam, overview of the results, reasons for limited exams, a summary or impression, and clinical indications. The report must be finalized or signed in the appropriate time frame. The interpreting physician's typed name and electronic signature must be present. The date the report is signed must also be indicated as the date of signature for MRI, CT, and nuclear medicine. It must be within 4 business days of the date of service. For nuclear medicine, the finalized signed report should be available within 2 business days. IAC provides online tools to ensure the success for your quality improvement program. The online tools include the quality improvement tool, the midterm audit, sample documents, and on-demand webinars. The midterm audit is part of the IAC's continuous accreditation program, and it ensures that facilities are following the requirements as outlined in the standards. It also provides a wake-up call to the facilities that they need to work a bit on their QI program. This audit consists of 2 parts: the quality improvement self-assessment audit and the preventative maintenance audit. For the midterm audit, facilities are notified that their audit is due 18 months after they receive their accreditation. It is done as a dedication to the IAC's initiative of continuous accreditation. Facilities need to self-assess several randomly selected case studies through the IAC's audit tool. They will answer questions regarding image report quality and receive an audit report. They also need to submit a service engineer or physicist report to ensure compliance with IAC standards. Again, this audit serves two purposes: to remind facilities that they need to have their equipment inspected by a service engineer or medical physicist on an annual basis, and to give the facility an opportunity to complete a thorough self-assessment of random images to ensure image and report quality. We consider this a tool, as this keeps the facility accountable to their QI program and the IAC requirements. Once you get accredited, it's easy to forget about the QI process until the next accreditation cycle. This audit prevents that from happening. IAC also provides sample documents in a repository for clients to access and model their quality improvement program. The client can review their current documents and compare to the requirements in the samples. Adjustments can be made to the client's documents to ensure compliance. The repository is located on the front page of the IAC website under the header of Helpful Resources. Webinars. IAC provides a series of webinars, both live and on demand, to meet the needs during a changing medical environment. The webinars are instructional and interesting and cover a variety of current topics in all modalities. IAC utilizes the subject matter experts from our large board of directors for the topic webinars. The Accreditation Simplified webinars are from our division directors. All webinars are free of charge and eligible for CMEs. They are available to anyone who wishes to attend, whether they are an IAC client or not. The QI tool is the crown jewel in our canon of helpful tools to assist our clients and non-clients for their QI programs. The QI tool ensures compliance with IAC quality improvement measures, provided the data included in the report is discussed during the facility's semi-annual QI meeting. It allows facilities to see exactly what IAC evaluates during accreditation review. The questions asked in the self-assessment within the QI tool are the same questions that IAC uses to determine accreditation status. This is essentially an open book test when selecting case studies to submit for accreditation. And note, this is a self-assessment evaluation. You will not need to send anything to IAC for review. This online tool is the platform that provides a self-assessment questionnaire for the evaluation of the exam and provides valuable feedback for quality improvement. It is available in every client's account and is open to non-clients as well. And again, this is free of charge. So let's dig into this QI tool a little bit deeper. Before you get started, if you're not an IAC client, you will need to create an account. If you are an IAC client, you need to enter your existing account. Everyone using the QI tool, clients and non-clients, will need to update the Manage Users tab and make sure that you have staff listed as QI users. The QI tool program will pull from the QI users list to do the self-reviews. To get started, you will need to go to the Quality Improvement tab in your account and click on Create New Assessment. Again, for non-IAC clients, you will need to create an account, but there is no charge for this service. Click on the modality you are evaluating and click on Create New Assessment. click on the Enter button, and you will then be able to enter case studies. You can enter in as many case studies as you want, up to the number of 30. But remember, you will want to keep this manageable, as we discussed earlier. Also, be sure to include a sampling of all types of case studies that you normally perform at your facility. To enter in more than one case study, simply click Add a Case. When you're done entering all the case studies, click on Start QI Process. Once you have confirmed the case studies, it is time to assign them to a reviewer. Remember, the QI tool will provide a drop-down list of eligible case reviewers from your QI users list that you entered in your Manage Users tab. You will assign the cases one at a time. For the first case study, select who you want to assign it to, then click on Next Case. Continue until all the case studies are assigned to a reviewer. Confirm that the information is accurate. Click on the checkbox and confirm assignments. When all case studies are assigned, click on Submit Assignments. Your reviewers will receive an email letting them know they have been assigned QI cases. They will need to follow the instructions contained in the email. When the reviewer logs into the account and clicks on the Quality Improvement tab, they will need to select the appropriate modality and then click on Review My Cases. A list will appear of the case studies that have been assigned to each reviewer. Before you begin the case review, be sure you have access to the images and case reports of all cases that have been assigned to you. When you are ready, click the Begin button. Continue through the review and select the best answer for all the questions. And these are the same questions that the IAC reviewers are asked during the accreditation review. When all the questions are answered, click on Submit, and the review for that case study is complete. When all the reviewers have completed an evaluation of all the case studies, you are able to view a report. Go into your account and click on the Quality Improvement tab, and click on the View button. This is an example of the report, which demonstrates the areas in which you can improve. These measures are the requirements for compliance with the IAC standards. Now we're going to talk a little bit about image quality. So what makes a good exam? That's an excellent question. And of course, that would depend on the modality. Common in all modalities for a quality exam is clear, high-resolution images. The exam must cover the pertinent anatomical structures and be free of artifacts and motion. Motion is the most common artifact throughout all the modalities. Computed axial tomography. There are many different factors that attribute to a good CT exam. The imaging technologist should first obtain a thorough history from the patient to assure the proper protocol is used. Also helpful is to look at the past imaging history to see if the patient has had previous scans. It is always best to match the previous scan protocol, especially if the referring clinician is following up on something. A CT of the abdomen can vary greatly depending on the indication. This includes contrast types and delay times for the scans post-contrast imaging. It is also important to properly screen the patient for contraindications to contrast, including decreased renal functions and a history of past contrast reactions. Other factors that affect image quality in CT exams with contrast include proper IV placement to assure a good injection rate and to avoid infiltration of contrast into the injection site. CT angiography studies require proper bolus timing to assure peak enhancement within the specific vessels being imaged. The technologist performing the exam must be familiar with bolus timing techniques. These can be done with the use of bolus tracking or a timing bolus prior to scan acquisition. For nuclear medicine, again, many factors contribute to performing excellent quality studies. Perform a good patient history and eliminate any possibility of artifacts from clothing. For patients with difficulty lying still, the duration of the scan can be difficult. Take measures to ensure that patients are comfortable. Patient body habitus can also play a role in image quality. Imaging longer to get appropriate count density is a prime example of obtaining good quality images. Once images are complete, review them thoroughly. Ask yourself, do you need additional scans or views? Does the patient need to be re-imaged, or can images be improved? Magnetic resonance imaging. There are many different factors that attribute to a good MRI exam. The first of which is safety. Without ensuring patient safety, a good exam is simply not possible. Once the patient's safety is secured, history obtained, exam orders confirmed, the patient changed, belongings locked up, and the process explained, you are ready to begin the imaging. Next step is to set up the protocol for the exam. Parameters such as TE, TR, field of view, etc. in an MRI exam are variable and can be easily modified. If there is a comparison exam, the protocol and parameters should be adjusted to match the previous exam, so the interpreting physician can compare apples to apples. The protocol can also be individually adjusted for the specific pathology that the referring clinician is looking for. Congratulations, the MRI exam is finished. Along the way, you should have been evaluating for quality as each sequence completes. You need to look for motion, artifact, resolution, signal-to-noise ratio, pathology, and anatomical structures. Artifacts. So we looked at what can make a good study. Now let's take a look at what can contribute to a bad one. Imaging artifacts are distortions or anomalies in a medical image that do not represent anatomical anatomy or pathology and can arise from patient motion, the physics of the imaging technique, or hardware and software limitations. Understanding and recognizing these artifacts is crucial for accurate diagnosis and treatment, as they can mimic disease or obscure real findings. For CAT scan, factors that can contribute to degradation of a study quality include motion, artifacts, or poor contrast timing. The image on the left demonstrates optimal contrast bolus timing. The one on the right demonstrates poor contrast bolus timing. And the dreaded artifacts, the motion artifacts. You see that on the images is demonstrated by motion. You see the misregistration as indicated by the arrows on both the abdomen view and the view of the CT of the sinuses. Artifacts in nuclear medicine are often misleading, that they appear to be pathological, but are caused by equipment malfunctions, patient-related factors like motion, or external substances. These artifacts can lead to false positive, false negative, or completely obscured diagnosis. This poster was presented at the annual ASNC meeting in 2024, and Mrs. Erin Stevens was gracious enough to allow us to use this. It is a great representation of PET CT fusion artifacts. The three main reasons are misregistration, intra-scan motion, and breathing artifacts. Instruct patients not to move between CT and PET images. Make patients comfortable prior to beginning the images. Shallow breathing, if at all possible, is requested to the patients. There are many artifact issues with MRI. Here are a few of the most common: motion, metallic artifacts, and truncation or Gibbs artifact. You can see the signal void and distortion artifact in the inferior portion of the eye. Can you guess what's causing this artifact? It's caused by mascara. If the orbit or eye was the focus of the exam, this would be considered a non-diagnostic exam. Also, there are safety issues for metallic components near the eyes. Makeup does contain metal particles and may have to be removed. The same goes for nail polishes. The current range for nails is a cat eye manicure. These contain a large amount of metallic components. If you are scanning the hand or fingers, all nail polishes have to be removed. This artifact in a sagittal cervical spine is a truncation or Gibbs artifact. It is caused by the cutting short of high-frequency data during reconstruction. A similar artifact can be caused by a swallowing motion. If it's a Gibbs artifact, increasing the number of phase encoding steps, decreasing the field of view, and swapping phase and frequency will help. If it's a motion artifact, allow the patient time to swallow in between the sequences. This is a dangerous artifact because it mimics the appearance of a syrinx. Motion artifact is the most common artifact in MRI, simply because MRI scans do take a long time to obtain. Motion will make any sequence that has it non-diagnostic. Some tips for reducing motion is a thorough explanation of what is expected, frequent breaks for the patient, and ensuring comfort with blankets, pillows, and sponges. In any modality, artifacts can be worrisome as they can hide or mimic pathology, as we've said before. So to summarize, having a robust quality improvement program can reap many benefits, some of which include improved efficiency, increased customer satisfaction, foster a culture of continuous improvement, enhance safety, improve patient outcomes, and increase revenue. As in all things, a successful QI program is based on one thing. You get out of it what you put into it. Be thoughtful about what you're trying to improve. You want to provide meaningful data that will really help your patients, facility, and staff. Obtain support from key personnel in your facility who truly care about accurate results and finding areas for improvement. And one final thought. Just as important as finding areas that need improvement, you need to celebrate when you identify areas of success. Excuse me. Make sure your staff knows that their hard work and reception of constructive critique has paid off with improvement. Thank you.
Perfect.
Linda?
Thanks. Yeah, thanks, Darlene. I've got a few questions that have come in. The first one is, can you please explain more about thresholds?
Yes. Thresholds are the determination of what will make a good quality improvement and what will make a bad quality improvement metric. You would need to observe the metric and take an average, like we had explained before, the average time that patients wait in the waiting room. And then you place, if they wait too long, this is what we will need to do for intervention. And it also applies to refining your QI program. You want to make sure that your program stays fluid just in case other items crop up during your review, and you'll be able to address it. But thresholds really are the key to getting your results and having some very defined, this is good and this is bad.
Okay, great. Another question that's come in. How many cases do we need to put through the quality improvement process?
That would kind of depend on your practice and what you're trying to achieve. And I always recommend that you select enough studies to make your evaluation meaningful, but not too many to make a burden for you. If it's too many, you just won't be able to do it. You won't have the time. You just want to be sure that it is manageable. And, depending on what you're evaluating, please make sure, like if you're evaluating image quality, please make sure that you get a selection of images that covers the whole spectrum of what you normally scan. If you hardly ever scan cardiac, you might not want to include that in your metrics. But if you scan a lot of knees, you want to be able to put a lot of knees into your evaluation. So make sure it's meaningful and make sure you cover all of your studies that you perform.
Okay, so how do we explain to the patients that they have to remove their makeup before they have an MRI?
That's a good question. Cosmetics and visual enhancement are always a difficult bridge to cross, and that, along with makeup, that counts piercings, because piercings are, very prevalent in the cosmetic industry, and they can cause problems also. In the interest of patient safety, it has to be done. You want to start before your patient arrives for the appointment. They should have had like an initial pre-screening and preparation phone call, and you can explain this as part of their preparation. Explain that they have to remove, as many piercings as possible. They may have to remove all of their makeup. And, that often doesn't sit well with a lot of people, but that is essential. I do remember many years ago doing mammography, that it was determined that antiperspirants could not be worn during a mammogram. And a lot of patients, it was difficult to get that across to them. But, 30 years later, it's just routine. So it's just a matter of getting in a habit of, informing the patients, making them completely aware of the dangers. And that should be, a pretty simple thing to go through, eventually.
So what is the roadmap for starting a QI program in your department?
Okay, good question also. The first thing you want to do is just determine, the scope of your practice and what you are looking for. You want to, we had said that it is defined. You want to define the measures for your quality improvement program. You need to analyze and set your thresholds of, what is determined for each metric, what is determined to be a good value or a bad value. You need to analyze the data once you determine your thresholds. If you find anything that has fallen above or below the metrics, the thresholds rather, you need to determine your corrective action plan, and then how you're going to implement that. After you do that, you need to, keep going back to it, and that is the control portion of the QI program. You don't just want to say, okay, we've solved this problem and we're not going to look at it again. You need to look at it all the time. Number one, to make sure that you don't regress in any of your metrics. And number two, you might find other reasons that need additional corrections in this metric. And that's how we have stated several times that your QI plan needs to be fluid. It's not just a one and done thing. It's a continuous process that you have to look at all the time.
Okay, great. I mean, can these strategies be applied across all modalities, and who are the key personnel in the development?
Yes, this could be applied through all modalities. Your nuclear medicine QI program is going to differ greatly from your MRI QI program, simply because they're just different animals, and the metrics will be different. So it can be applied throughout all modalities, but it will look different through the modalities. As far as who you want to select to help, that's an important item. You want somebody who cares about the QI program. It's not just a duty for them. They have to really care about it. You want to engage likely your chief technologist, and really anybody who has an interest in it. This might be a way of elevating this, some of your staff to the managerial aspect. So that could be, a promising thing for a lot of staff members. But again, I think the key element in selecting people to help you is that they need to care about wanting to improve the process.
Great. Thank you so much, Darlene. We haven't got any more questions, so I'll wrap up there. So thank you so much for your time today and for a great presentation. And also thank you to the IAC. Now, if you want more information from the IAC, please visit intersocietal.org. As promised, the answer to today's trivia question is pearl or white. So congratulations to our winner, Natalie Quinn in Kentucky. Now, just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of this webinar. You must complete the survey to receive your 1 Art Category A CE credit by the HRA, and you'll be able to download the certificate directly from your computer once the survey is submitted. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. Now, if you've missed any of our past ICE webinars, including any by the IAC, please visit icewebinars.live to view our whole webinar archive. So thank you all for your time today, and I hope you enjoy the rest of the day and have a great Thanksgiving next week.